Welcome back to the Diet Doctor podcast with Dr. Brett Scher. Today I'm joined by Dr. David Diamond. Now, Dr. Diamond has a PhD in biology, and he's a professor in the Department of Psychology at the University of South Florida. Now, interestingly, his work is in cognitive and neuroscience, and he's done this for decades. But because of a personal journey, he has now gone down this whole path of cholesterol and statins and low-carb lifestyle, and really trying to say, what does the science say? What does the science support in this realm? Now, this is a polarizing topic, especially with mainstream medicine, mainstream cardiology being very much in the camp of LDL is causative of heart disease. And Dr. Diamond is on the other side of that, saying, wait a second, I don't think the evidence supports that statement. Now, I've got to be honest, this is a very important topic for me, a personal topic for me. I had a huge list of notes, and I kind of went a little bit all over the place because I was just so interested in talking to him and talking about the different topics and getting his thoughts on different things. So I apologize if this interview doesn't flow as seamlessly as I would have liked. But I think we cover a lot of different topics. Now, quick disclaimer though, if you have high cholesterol, if you are on a statin, please do not make any medical decisions or changes based on this discussion. This is merely to explore some evidence, to explore one side of this equation, hopefully in a balanced way. But if you're going to make any changes or any decisions about your medications or your health, please talk to your doctor first. Do not make any decisions based on this discussion alone. Now, with that disclaimer, we talk a lot about the science. We talk a lot about the practicality of how this applies to individuals in a low-carb lifestyle. And we explore a number of different topics about cholesterol, LDL, statins, and their benefits. So a couple quick definitions, which I think we go over, but relative risk reduction versus absolute risk reduction. So if you have a 1% risk of something and you can reduce it down to 0.5%, the difference, the absolute difference is 0.5%. That's the absolute risk reduction. Relative risk reduction, however, would say that's a 50% reduction because 0.5% is half of 1%. So we talk a lot about that. Dr. Diamond's been very vocal about sort of truth in advertising between those two things. We talk about Mendelian studies, and basically that's just a natural history experiment of genetic mutation and following what happens to people over time with that genetic mutation. That's called a Mendelian randomization trial. I think I use that term a little bit in here. I think hopefully that's all the definitions you need, and I hope you enjoy this discussion with Professor David Diamond. You can see the full transcripts on dietdoctor.com. Again, please realize this is not medical advice. This is just simply exploring a fascinating topic with a fascinating human being. So enjoy this discussion with Dr. David Diamond. Dr. David Diamond, thanks so much for joining me on the Diet Doctor podcast.
Thanks for inviting me, Brett.
It's a pleasure to have you here because you really have been a spearhead in this movement of questioning the role of LDL, questioning the role of statins, and more importantly, how does that apply to a low-carb lifestyle? But this is not even your job. This is not your profession. I mean, you have a regular job as a professor in the Department of Psychology. So tell us a little bit about how you got from point A to point B here.
Right. So my training, my primary expertise is in neuroscience, studying the brain and memory, which I started over 40 years ago. But what happened about 20 years ago was that I found that I had extremely high triglycerides. I was actually diagnosed with familial hypertriglyceridemia, which happens to about 5% of the people in the population. I eat some bread and my triglycerides go sky high.
Yeah.
My triglycerides were about 700-800. And with these people who have high triglycerides also have low HDL. So my ratio of triglycerides to HDL, which should ideally be like 1-to-1 or 2-to-1, mine was about over 20-to-1.
Wow, that's amazing.
And so, and it was for about 10 years. My doctor's keeping track every year. I'm getting blood tests. I'm working out like crazy. I'm on a low-fat diet. And every year I just got fatter and fatter, and my triglycerides are up. Finally, my doctor sat me down, said, you've done your best. Diet and exercise have failed. Just like I say in the commercial, you've got to go on a statin as well as other medication. And I just figured, well, I've got a background in biology. I know a lot about the brain, but not much about heart disease. Least I can do is read a few papers before I go on the medication. Read a few papers, and by this time I've now read a few thousand papers. And that has helped to guide me in my decision not to use medication. And instead, I learned about the value of a low-carb diet. I was able to cut my triglycerides by 75%, raise my HDL 25%, lose a good bit of weight, feel much healthier now than I did 20 years ago. So I'm a strong advocate for a low-carb diet, but also realizing that medication wasn't appropriate. And in the process, I've been, in a sense, indignant about the statin research. I actually express this when I give my talks about how I realize that the cholesterol theory, which is cholesterol causes heart disease through LDL, is really not well supported. And frankly, what I express is it's the obscene profits that have been made through the food and drug industry that have maintained a hypothesis that has failed.
Very, very controversial and interesting theory, which you back up with a lot of research. So I want to talk about that. But I think your example is a perfect example of what's happening in this low-carb world and the medical world in general, that whether it's an engineer or whether it's a scientist, frequently an outsider from the medical profession has a personal experience, but then they have the tools and the knowledge to dig deeper and provide us with a whole new perspective. And I think that's so valuable because in the medical world, if you're in your own echo chamber, only hearing the same people, the same experts, the same drug companies, although we fall into that same risk, I guess, in a low carb world, right? We all, we can be our own echo chamber too. So we have to reach out into other areas and keep our ears open for other opinions. Now, one of the things that you're very critical of is evidence and how we portray evidence. And we talk about evidence-based medicine all the time, and we talk about what's the evidence for keto, against keto. What is your perspective as you've looked into things about the state of evidence in the medical world?
Well, I think it's very important that I don't come in with a bias. I've actually been very well funded by drug companies in my neuroscience research, and I'm not personally or professionally opposed to any drug company research. I had never seen the distortion of data, distortion of the presentation of data before going into the cardiovascular field, before reading papers on effectiveness of treatments with the cardiovascular, particularly lowering of cholesterol drugs. And I had to tell you that I was astounded, I was offended when I saw how the data were manipulated to greatly overstate the benefit of cholesterol-lowering drugs, which actually goes back decades, originally talking about cholestyramine in a 1984 paper, in which you had, starting off with about 500,000 men, they got that work down to about 6,000 people of the highest levels of cholesterol, and using an older drug, cholestyramine, which lowered cholesterol.
Right.
The amazing thing is after 7.5 years, there was virtually no effect. And there was no real statistically significant effect. It was a 0.4% difference between treated and untreated men. And I look at that, and what they should have said was, something, we were wrong. Lowering cholesterol really didn't have any benefit whatsoever. But they turned that 0.4% into a 24% improvement in outcome. And so this manipulation of the data, and that's using relative risk rather than reporting the actual outcomes.
Right.
So to me, this is just not right in how you report the data to the public and to the medical field.
Yeah, you've been very vocal about the relative risk versus absolute risk. So the absolute risk in that setting would have been the 0.4%. But when you do it in a percentage, it's a relative risk. So if you have a 1% risk, you lower your risk to 0.5%, that's a 50% reduction. Now, what's interestingly, as a cardiologist, I've been inundated with that type of relative risk reduction publicity. And to me, it was just how it was done until I started, digging a little bit deeper and realizing it's a completely different conversation if you have the absolute risk reduction. But the fallback is there is a change. There is a difference. So even in the statins, and I guess maybe we're jumping a little ahead here, but even in the statin trials, if there's a 1% difference, it can be a statistically significant 1% difference, which then they publicize as a 36% difference.
Right.
But it's hard to argue that there is a difference. So the question becomes, when is it a big enough difference to make a clinically useful intervention? And that's a hard question to answer, isn't it?
Well, the first thing is, in a sense, we need truth in advertising. We need accurate reporting.
Yeah.
So what's very important is to report both the absolute risk and the relative risk. They should both be in the abstracts. They should both be presented to doctors and to patients. People should know both. What is actually the difference in the rate of events in people at placebo versus the treated people? you shouldn't only be told the relative risk because that's deceptive. And we know studies both in doctors and the public, when you hear about a 50% reduction in risk and that's all you hear, you think that half of all people are now not going to have a heart attack.
Right.
And that's exactly what doctors interpret that.
Right.
So again, first, I'm not against actually just reporting a 50% reduced risk with statins, but that's got to come along with the absolute risk as well. People need to have both data forms. And the second thing is, you are right. There are numerous studies showing benefit with statins. And that benefit typically is on the order of single digits. There's never been a statin study I know of in which you actually have a double-digit improvement. And I have to just briefly tell you, in my field of neuroscience, where we actually study depression, there's great controversy because people with mild to moderate depression given a placebo have actually a rather dramatic effect. There's a benefit. And the controversy is that the antidepressants only improve outcome by 10%. Compared to placebo. Well, there's never been a real 10% improvement in outcome of any kind with statins. So what I agree with you completely. There are studies that have shown some benefit of statins, whether you're looking at coronary events as well as coronary mortality and all-cause mortality, and those numbers are relatively small, but they are real.
Yeah, I think that's a great perspective that you bring from the field of psychology and depression, that they're looking for a 10% benefit, and we're talking about 0.5% to 1% benefit. Right. And it's interesting the phrasing, the wording of these studies, that they're blockbuster, that they're revolutionary. And I think we've sort of lost perspective of what blockbuster and revolutionary really are. Like treating tuberculosis, that was revolutionary. That was blockbuster. Sanitation, anesthesia, those are blockbuster. 0.5% difference is that a blockbuster. But then people say, well, cardiovascular disease is the #1 killer in the world. Millions of people are going to suffer from cardiovascular disease. So if we can make a 1% difference, that's a lot of people. And in a way, that's a valid argument when you're talking about a population basis. All right?
I agree completely. If statins had no adverse effects, and you save 1% of the people from having a heart attack, well, I'd be all for it.
Right.
I'd take it myself if we were absolutely certain there were no adverse effects.
Yeah.
It's kind of a crapshoot. Think a 1% effect means that 100 people are going to take the drug and only one person out of 100. 99 take the drug and then there's no benefit whatsoever. But again, it gets down to adverse effects. Now, what has happened is people are really not aware of the adverse effects. They've been greatly minimized by the key opinion leaders, and I've also talked about this. Now, we actually were invited to write a commentary recently by PLOS ONE, and in that commentary, which just came out a few months ago, we reviewed the literature on adverse statin effects, and it's not small, it's extensive. Mm-hmm. We reviewed about 60 papers published in peer-reviewed medical journals on about 20 different categories of adverse effects. The most obvious is development of type 2 diabetes, and this has really been minimized by the key opinion leaders. But when you actually look carefully and you have an RCT, an actual trial in which you get blood samples and you look at the A1C levels and you look at fasting glucose as well as other insulin measures, you actually find that over the course of 6 years, this is in men, that there's a 5% increase in new onset type 2 diabetes. So in this particular one was done in Finland, funded by the government, which you have a spontaneous increase in type 2 diabetes with placebos 5%. But in those that were on statins, it was actually 11%. So it's a doubling in the rate of type 2 diabetes, which is a relative risk measure.
Right.
But we're not talking about 1%. We're talking about a 6% increase over the course of about 6 years. And so that's just one adverse effect. There are really well-described cognitive effects. We've published a paper on cognitive effects of statins. And there's actually a beautiful paper that has shown that people diagnosed with dementia, older people diagnosed with dementia, which when they were taken off the statin, the dementia disappeared. Put them back on the statin, the dementia returned. This is not something I think doctors are aware of, the extent of the adverse effects of the statins.
Yeah, it's very interesting because when you talk about adverse effects of statins, the most common is the muscle aches. That's what everybody talks about. And the argument is you can't compare muscle aches to heart attacks, right? Those aren't on the same level, especially when the vast majority of the muscle aches disappear when you remove the statin. But even with the muscle aches, there's significant controversy. I mean, you look at the trials and they report 1 in 10,000 risk of significant muscle aches. And of course, these are designed by the pharmaceutical companies. There's a run-in period which weeds out a lot of the people who would be intolerant, so they're not included in the trial. But then my favorite is how you called out Rory Collins, that he would state there's 1 in 10,000 risk of statins, but yet his commercially available product to test for statin myopathy risk quotes a 29% risk. Right. So where do you see in trying to evaluate the evidence, where do you see the muscle aches really lie? Where do you think that is? Where's the real number?
This is very interesting because you listen to the leaders of the field. Steve Nissen, for example, calls it a nocebo effect, in which the person is told statins cause muscle aches, and therefore they say they have statin-induced muscle aches. Yeah. But he calls it actually a nocebo, meaning it's all in their head. And there's some very poorly designed studies that support that. What I'm presenting today is actually Steve Nissen and Christy Ballantyne and Steve Nichols, strong statin advocates, talking about muscle pain caused by statins. Yeah. They're not calling it a nocebo effect. And their estimate is 40% of the people taking statins stop taking it in part because of muscle pain. So I caught them on a video in which they're being candid about what actually happens in the clinic, why people stop taking statins.
Interesting.
Yes.
Yeah. And it is difficult to decipher the real life effect, the physiological effect versus the placebo or nocebo effect. That's why you need a randomized controlled, placebo-controlled trial, but those trials frequently excluded people who are at risk of having muscle ache. So right. I don't think we know the true answer. But the bottom line is, if you think it's causing you muscle aches and you're not going to exercise because of it, we have to ask, is it impacting your health favorably? And it makes right. you wonder, doesn't it?
Well, that's another important point. What happens is we know that statins interfere with metabolism. You have less CoQ10, which muscles need to be able to have energy. Yeah. And there's some very nice work from out of UC San Diego. I'm blocking on her first name at the moment, but Galom, and it'll come to me later. But very nice work showing that people have fatigue much more rapidly, especially under exertion conditions. Yeah. And so we do have less energy. People have less energy when they've taken statins. And we do have muscles breaking down, which contributes then to kidney disease, kidney injury. This is well established, actually, published papers. So I think we're looking at very real physiological effects that have adverse effects globally on the body.
Yeah, so we started with the muscle aches, and then diabetes is right. the next big one. And what's interesting about the diabetes is people say, well, look, if you're having an increased risk of diabetes, but you're still showing a reduction in cardiovascular events, doesn't matter. And that's very interesting within a 5-year trial. But when people are on these drugs for 20 or 30 years, we're left to determine how are we going to interpret that data. On the one hand, people say, well, if the cardiovascular benefit is 1 year at 5 years, it's going to be 2 years at 10 years and 4% at 20 years. Okay, maybe we can make that reach, but how is the diabetes going to impact that? And we don't right. know the answer to that question, do we?
Right. No, we don't, because most of the trials are stopped at about 3 or 4 years. It's Beatrice Galom, by the way, at UC San Diego. She came back to me, and she's done some wonderful work looking at statin effects. What you'll find with the statin advocates, and I look at this really is, it's outside my primary area in which I was just a basic scientist, and I'm still a basic scientist looking at brain function. But to see people now who I consider advocates for statins, that's not the way science is done. And what's happened with the statin advocates is they consistently take that number needed to treat, which may be small after 1 year, and then they simply change it. I mean, it's 1 out of 100 people will actually have a benefit from statins. And then they'll say, well, after 20 years, you only have to treat 5 or 10 people because that benefit will accrue over the 20 years. Right. And they refuse to say, well, the adverse effects can also accrue. So if we're looking at 6% additional people develop diabetes after about 5, 6 years, well, what's going to happen after 20 years? And then what happens if there's actually an exponential increase in adverse effects? Once tissue starts breaking down, then you've got to be even more concerned that happening at a more rapid pace, especially with elderly people. Right. And by the way, also, the way I also present this is, if the tobacco companies had the control that the drug companies have now, overlooking only with the onset of starting to take the statins after only about 4 years, if you look at development of cancer, lung cancer, only 4 years after you start
4
smoking.
years after you start
We
smoking.
never would have known about the link of lung cancer to smoking. So understand, these trials are stopped really before most cancers can develop. But when you look long term, and there's actually a nice epidemiological study looking over 10 years, you see twice the rate of breast cancer in women who are on statins chronically compared to equivalent groups of women either with high cholesterol, low cholesterol. And so there's also evidence of cancer in men as well. But you've got to look either at older population, more vulnerable, or a longer period of time.
Yeah, that's interesting because that's where there's some contradictory evidence because there's meta-analysis showing no increased risk of cancer as well. And it all has to do with which trials do you include, how long's the follow-up, and it becomes confusing and it's difficult to say with certainty. But then you hear these statements, the preponderance of evidence, right? Taking the evidence as a whole shows that statins reduce cardiovascular events. Now, that's also difficult because where does the preponderance of evidence come from? It's mostly pharma-sponsored trials. So how do we interpret pharma-sponsored trials? I mean, the data is still the data, right? You can't. It's not like they're falsifying the data. But what is the impact of the pharmaceutical companies have on the data we're seeing?
I actually give pharmaceutical companies a lot of credit. I don't see any evidence of fraud. The deception is how actually the clinic directors present the data to the public and to the medical community. And again, that gets back to the relative risk versus absolute risk. The fact that they report such minuscule beneficial effects, to me, I give them credit. That clearly, to me, there doesn't appear to be any reason to accuse them of fraud. Because they're showing so little benefit. And again, I don't think we want to automatically demonize studies that are funded by pharma. These are very expensive studies, and it's very difficult to get government funding for long-term studies on cardiovascular disease. The other real challenge is it's a very low rate in which people actually develop heart attacks. About the only time you see a high rate of death is with heart failure, of which statins are absolutely no benefit at all, and people with high cholesterol live much longer than people with low cholesterol following heart failure. But when you're looking at heart attacks, you actually see in the general population such a low rate that, frankly, to give the pharma credit, it's difficult to see much of a reduction in heart attacks.
Yeah.
I mean, you even take people at high risk of heart attacks, and you'll only get about typically 3, 4, 5% that will actually have heart attacks, and you have a low rate of mortality.
Right.
So this is part of a methodological challenge for this area of research. It's not like in a cancer study, you may very well have 50% of the people die in a short period of time. But in these heart disease studies, I don't think people appreciate that there really is a relatively low rate of events in placebo-treated people.
Right.
And this is why I tell people, I show them a study, such as the Lipitor study, which was very famous in Lancet. About 2000, or so the heart protection study, the British heart protection study, you're only looking at about 3 or 4% of the people have died. They're terribly uncooperative, is the way to present and about 97% of the people don't have heart disease. And the way I also present this to people, I say, listen, you can go to your doctor and say, if I don't take the statin, if you give me a placebo, what's the likelihood in the next 5 years I'll have a heart attack?
Right.
And the answer is 97% likely that you will not have a heart attack. And so, to me, that's the reality of it as well.
Yeah. So that goes down to from a doctor standpoint, the shotgun approach of let's give this drug to as many people as possible, hoping one is going to benefit, versus the more laser beam focus of let's really find out who's at the highest risk and then maybe add statin as part of their regimen. So how do you interpret the calcium scoring data that's come out recently? You know, the one big study out of Walter Reed that showed absolutely no statin benefit if your calcium score was 0. It showed a very small benefit if your calcium score was between 1 and 100. I think it was the number needed to treat was about 100 over 10 years.
Right.
But then as that score goes above 100, all of a sudden the number needed to treat to save one cardiovascular event, not death, but cardiovascular event, goes down to 12. So how do you think about that more laser-focused approach than trying to better identify who might benefit from a statin as one part of their overall treatment program?
Right. So I think there is evidence, actually going back to the 4S study from 25 years ago, now including the calcium scores with people, show that the people that are more vulnerable to develop heart disease do benefit from the statins. And so you're absolutely right. That study showed that the people that had the high calcium score showed a benefit, reduced coronary events, no difference in mortality, as you say, as well. And I think it's actually important to go back. This relates. Well, first of all, when we're talking about calcium score, I want to point out, everyone agrees high calcium score is unhealthy. I mean, this is a fact. The interesting thing is numerous studies have come out now showing that people on statins have increase in calcium score.
Right.
This is also, there's no difference of opinion on this. The remarkable thing to me is now that we say, oh, well, that must be a good thing because increase in calcium stabilizes the plaque. This to me came out of nowhere. It's like increased calcium score is bad unless it's induced by the statin.
Right.
Then it becomes a good thing. So that's remarkable to me. But what I will yield here is that there is evidence of benefit of statins given to people with high risk. And the important thing actually is there's an analysis of people in the 4S study. That was done 25 years ago using simvastatin. And what you actually had, that was one of the biggest effects ever, in which you actually had a 4% reduction in mortality for secondary prevention. People already had a heart attack.
Right.
And frankly, you have to go back 25 years to find any study that was as good as the 4S study. It shows how weak the effects have been since then. But even accepting that it was a study run by pharma, the data were analyzed by pharma, it's okay, a 4% reduction in mortality for people at high risk. A reanalysis of that study came out 7 years later, published in Circulation, and it showed the entire benefit was in people that basically had metabolic syndrome, people who had low HDL, high triglycerides, and high LDL, the entire benefit. Now, when you look in the 4S study, which is so important, the people that had the same high LDL but high HDL and low triglycerides, secondary prevention, no benefit whatsoever. And this is so important getting back to low carb, because that's exactly what happens when people go low carb. Their HDL rises, their triglycerides drop, just like it did for me.
Right.
So what this is saying is you have a choice. Okay, you can take a statin and have a basically crappy metabolic syndrome, or you can go low carb, make all those improvements, and there's evidence the statin won't have any benefit over that.
I think that's a great perspective. I want to talk about that real quickly, though, going back to the statins causing increased calcium. I think that's a great point, how the immediate reaction from the medical community was, oh, this is a good thing. And to be honest, we don't know. It could be perfectly correct. You know, there's a mechanistic way to think that that is correct. But to not have the evidence and just dismiss it because of a mechanism would get thrown out if it was contrary to the common belief. And that shows how a common belief can really direct a conversation. Maybe right, maybe wrong, but it's just a perfect example of that. So I think that was good. All right, now getting back to the LDL and the environment it's in. And that's something I think we really lose perspective of. Because even going back to the Framingham data, same thing. There was an association, a complete total association between rising LDL and rising cholesterol and risk of cardiovascular disease. But when you see the Framingham offspring data and they break it down according to HDL levels, all of a sudden that association is lost at higher HDL. So it shows there's something to this more than just LDL. And it probably has to do with metabolic health. And like you said, a reevaluation of the 4S trial says that. Now, that being said, though, LDL is causative of cardiovascular disease. We heard it in 1980s with Brown and Goldstein. We heard it again last year with the European Society of Cardiology. The definition of cardiovascular disease is an ApoB-containing lipoprotein in a macrophage in the arterial wall. Therefore, it is causative. Now, with so many people certain in the medical community that it is causative, what are they missing?
Wow. So when you say it's causative, you're just quoting. I don't know if that's your opinion.
Sorry,
or not.
I should
you
say
are quoting the literature.
I'm quoting the literature, right? I'm not stating my opinion. I'm quoting what I see paper after paper
and
after
it's interesting.
paper.
You mentioned Brown and Goldstein. They stated as a fact LDL causes heart disease in the complete absence of any evidence. I mean, they did elegant work linking LDL receptor abnormalities to familial hypercholesterolemia, but they never showed that LDL actually was causative of heart disease. This is, again, where we have to actually look at the evidence. That's all I really care about. So we have a drug that lowers LDL as much as statins and also raises HDL. This is the CETP inhibitors. So the great thing about this drug is a completely different mechanism from statins. And initially it killed people. And so those trials were stopped. So people are dying with lower LDL and higher HDL. But after that, they were able to clean up the drug so it has almost no side effects. The CETP inhibitors, drug companies invested over $1 billion. This was to be the blockbuster because not only did it lower LDL, it raised HDL. This is one of the biggest failures ever in pharma history. So these are people who are primary, secondary treatment with the drug, dramatically lower LDL, and absolutely no difference in coronary events or mortality. So no benefit, no harm. This, to me, is sort of the death knell for the LDL hypothesis. This is saying, no, you're lowering LDL and you're making no difference in coronary events.
Yeah.
So that's the first thing. The second is, what we have to realize is there's a lot of money involved in blaming LDL for heart disease. What we got is a new generation of drugs. Well, let me back off. A lot of people say it doesn't matter whether statins lower LDL or not. As long as statins provide a benefit, we don't care about the mechanism. And that's one side of the argument, which actually we can talk about.
Yeah.
If statins have a benefit and they don't have an adverse effects, fine. Who cares how they work? But what has happened is we have this new generation of drugs. That's the PCSK9 inhibitors. This drug specifically targets LDL. So if we actually look objectively at the research and we drop LDL and we simply accept that LDL doesn't really cause heart disease and statins work and we stop right there, that would be fine. But because the drug companies have invested over $1 billion in the PCSK9 inhibitors, we've got to continue to target LDL. Now, part of this is I always talk about familial hypercholesterolemia. These are people with extremely high LDL levels, 2-3 times normal. And in my papers that I've written, in what I'll be covering my talk today, I'm covering how people with FH, people with LDL 200 to 300 or more, live a normal, healthy life, that they have a normal lifespan. These are people who live into their 70s and 80s with total cholesterol of 400 and LDL 300. Well, that's clearly counter to the idea that LDL is killing people.
Yeah.
It doesn't make sense.
Yet there's a subset that clearly develop cardiovascular disease at a young age and die at a young age, but when taken as a whole, the overall life expectancy is not that much different. And when you compare those who get early cardiovascular disease to those who don't, it doesn't seem that LDL is the predictor, does it?
Absolutely. No. And again, let's be clear on the numbers. When you look at it's a ratio of the rate of death for each decade of life. So the first thing is only about 1% of people die in their first 20 years. In modern society, we have very low mortality rate first 20 years. And when you look at rate of death for people with FH, that is not statistically different from people in their first 20 years, 20 to 30, 20 to 40. There is no overall difference in death rate. It is remarkable. There is a greater increase, there are greater incidence of coronary events, but the actual death rate, this goes back whether you're looking at the 1960s to Harlan's work, through the decades, there have been a half a dozen papers published, and Mundal et al., this is beautiful work out of Norway, in which you're looking at about 5,000 people, documented FH, in which you have no increased rate of death, all-cause mortality at any rate, at any age, and in fact, this is untreated. So this is not looking at statins having an effect. For people 70 years of age with FH, they have a significantly lower rate of death for the next decade compared to the general population.
Yeah, and that's
and LDL is clearly not relevant. Now, we publish a paper. My colleagues and I published a paper on medical hypotheses in which we reviewed the FH literature. And this is so important, and it's ignored by the statin advocates. You have so many papers that have shown that what kills people with FH is coagulation factors. These people naturally, comes along with high LDL, they also have a genetic anomaly in which they have significantly higher coagulation factors, higher fibrinogen, higher factor VIII, and their platelets are much more reactive to epinephrine. So you put some epinephrine in a dish with platelets, platelets coagulate. Okay, they aggregate.
Yeah.
Someone with FH, put their platelets in a dish, put in some epinephrine, they're 100 times more sensitive to epinephrine. than a control population. Now, you don't hear much about that because no one's excited about reducing platelet aggregation. I mean, who wants to just give aspirin to somebody that's got an FH, right? There's no money in reducing platelet aggregation, far more money in targeting LDL.
Yes, what's interesting about that is people have problems mechanistically understanding that, because there can be 20 or more different genetic variations, genetic mutations in the LDL receptor to cause FH. So how can they all individually also affect coagulation? It seems like a disconnect. The LDL receptor genes also affecting coagulation genes. So people have a real hard time mechanistically understanding that. Are you able to explain that?
I think that it's a different gene.
Yeah.
So there's actually a very nice study showing different gene forms for prothrombin, which is involved in coagulation. And it's the subset of individuals that have FH and equally high LDL between those who have cardiovascular disease and those who don't, but a subset of those also have the gene anomaly, which dramatically increases prothrombin, and those are the people who have cardiovascular disease. So it looks like it is potentially linked to the LDL gene anomaly, but it is a separate gene. And so only a subset of people with FH now have this reactive response, and those are the ones. The other thing to keep in mind, people with FH, just like everybody else, they're susceptible to the same risk factors. So the people with FH that smoke have a dramatically higher rate of heart disease, much more than the general population. And you talk about stress producing heart disease. Well, the FH person is going to be more sensitive to stress. And diabetes, so higher blood sugar, is going to triggers platelet aggregation. So the FH person will be more sensitive. But to the individuals that don't have these risk factors and yet have sky-high LDL, no heart disease.
Yeah, I think that's one of the most important points to make, is that the augmented effects. We know smoking's bad. We know diabetes, hypertension, metabolic syndrome are dangerous for your cardiovascular health. But for those with FH, it is a magnitude of order higher risk than for the average person.
And I think it's important for the person with FH to realize that this is across the entire population, that it appears that they all have this increased susceptibility to platelet aggregation. But it's the subset then that have the additional risk factors, such as the high blood sugar. But you know what is disturbing to me is that I read the reviews on FH. I read about treatment for FH. And we're talking about 20, 30 authors writing a massive review on FH. The word platelet does not come up once. Coagulation does not come up once. It total focus is on LDL.
Yeah. That's interesting. I mean, do they just not... They just disregard that it's even an issue because the papers are there, the science is there. You might say, I don't believe it's as big of an issue as some are making it out to be, but you can't ignore that the science is there and have to address it.
That's what they do.
Yeah.
And it's not just one or two papers published here and there where people can't find it. We're talking about 50 years of research, looking at people with FH. And there's some anomalies that are kind of interesting. The people who get their FH, it's heterozygous, so it's either from one parent or the other. It just turns out there's a maternal influence. People who get their FH from their mother are much more likely to develop heart disease than people who get it from their father.
Really?
Yeah.
I haven't seen that.
Well, it's out there. It's confirmed. LDL levels appear to be equivalent.
Interesting.
Yeah, it is really interesting. And it says that maybe, I've hypothesized that maybe the coagulation factors come along with getting maternal FH and not with paternal FH. They may be more reactive. But nobody's talking about this.
Yeah, there's no money in studying it. And there's no real benefit in studying it because we have the boogeyman, we have the treatment. So why complicate the issue? Right?
Well, that's also the other thing. There has never been a study on FH, going back 50 years, never been a study on FH with a placebo-controlled trial.
Right.
And there's a lot of modeling that you'll see. But no one has ever, from the beginning, they felt it was unethical. That we've got people with FH, we've got to give them a treatment, 2 different treatments, because we've got to be able to save them. And it turns out, the way to look at it is there's no evidence that statins have any benefit or any other treatment has a benefit in FH because it's never been compared to placebo.
Right, but historical data shows in the statin era, risk of cardiovascular disease has decreased tenfold, is what you would read in most papers, since statin treatment has been instituted. Now, as we know from epidemiological studies, there are lots of other things that can happen and coincide with that, but the relative risk drop since statins have been introduced is impressive. I mean, when looking in data from that standpoint. But my guess is you have a different interpretation of that.
Well, no, it's just a matter of looking at when is it that death from coronary heart disease has declined. It actually began in the 1960s. So death peaked in the 1950s, and you can actually see that decline began in the 60s, and really the slope of that decline hasn't changed much with statins. And the statin research has really shown very little effect on overall mortality. So there's no reason to believe that the statins have any effect on population mortality from cardiovascular disease. So clearly, in fact, I remember there are papers you'll read in the 1970s questioning why is it so much fewer people are dying of heart disease now than they did 20 years ago. So that it may very well be that it is better care, and it's actually post-coronary care that may very well be reducing. It's death from heart disease that has declined over the last 40 years or so. But probably the incidence of heart disease may even be increasing along with obesity and diabetes. But I actually would attribute potentially the use of antibiotics. It's potentially very important because you do see a linkage of infectious disease with heart disease.
Yeah, we hear about smoking, we hear about blood pressure management.
Yeah, that's so important.
All of those, right.
The decline in death from heart disease has come right along with decline in smoking too, which again peaked in the 1950s and 60s.
Could it also be treating tooth abscesses or treating, chronic smoldering infections? The point is we don't know the answer. We can come up with lots of hypotheses.
But statins don't deserve the credit for reducing it because it preceded statin development by decades.
Yeah. Oh, okay. We kind of went down a little rabbit hole, which I think I'm going to do a lot with you here because there's so much to talk about. But I was starting from the point of asking the question, is LDL causative of cardiovascular disease? And sometimes I do get in trouble of making statements and make it sound like I support them when I'm really sort of quoting the literature and trying to play devil's advocate. But I think there's so much controversy about being involved and being causative, and we blur the lines far too often. So, I mean, would you agree that ApoB-containing lipoproteins, like LDL lipoprotein, are involved in the atherogenic process and involved in developing cardiovascular disease?
It's certainly possible, and I'm open to any possibility. I'd like to learn more about it. But what just doesn't make sense to me is when you look at people that have astronomically high LDL and they don't have heart disease. If we're talking about it being causative, I mean, why? I mean, why is it not causing it all by itself? Well, they'll talk about the environment, the metabolic environment. Well, what you've got is a harmful metabolic environment. You've got people that have high blood sugar and high blood pressure, which is causing damage to the endothelial. It's causing damage to the vasa vasorum. And potentially one could say, and you've got infection, that the LDL is found at the scene of the crime.
Yeah.
And again, it gets to association versus causation. I mean, the police are always found at the scene of the crime, and so one can make an argument the police have caused the crime. It's the same kind of argument. There's good evidence that LDL works with white blood cells, with macrophages, to target pathogens, to target and be able to kill viruses and bacteria. And that is why, in fact, you find LDL in damaged artery. It is, and you also find white blood cells. No one is saying that, well, white blood cells obviously must be atherogenic.
Right.
You find calcium in the artery. Well, calcium must be causing heart disease. You find lots of stuff. You find bacteria in these arteries. Well, bacteria are causing. LDL is found along with a lot of other things inside the arteries. And essentially, there's so much work showing that LDL is a part of the immune system. And when you find actually bacterial remnants, this is very common in the plaque, you find bacterial remnants, infection is often associated with heart disease. And so LDL is found where you have infection.
Right.
And so that helps to understand LDL's role, which is a part of our immune system. So I would say at this point, there is no evidence of causation. And in fact, we also, to take it to another level, there are different kinds of LDL. And this is so important to the low-carb community because what we have to see, this is so obvious, is that the LDL changes depending on the environment. And so what you find is, and this is so much work by Ron Krauss and others, is that the LDL changes under a condition of low blood sugar. So you don't have that abnormal LDL. I mean, natural, native LDL is large, as I say, large and fluffy. And when it's surrounded by sugar, it's glycated and oxidized. Well, you end up with what's called small, dense LDL. It has much less cholesterol in it, and it's much more reactive. Well, the way to think about this is that is not the way LDL is supposed to be.
Right.
That small, dense LDL is associated with an endothelium, that's the lining of the artery wall, that's damaged. And so what you got in conjunction with too much blood sugar, too much blood pressure, and then you've got damage to the wall. The LDL itself is damaged. So I would actually say at this point, I think small dense LDL is potentially, think of it as atherogenic,
Yep.
but that's because it's contributing to the noise. It's contributing to the damage.
Right.
But the native LDL in a healthy person is not contributing to damage.
So here we have a lifestyle intervention that can improve metabolic disease, improve insulin levels, glucose levels, can take small dense LDL, make it the larger, fluffier LDL, can lower triglycerides, raise HDL, lower blood pressure. It can do all these impressive things.
Right.
Yet the medical community is afraid that it can also raise LDL.
Right.
So would you say this is a completely different paradigm and environment than has been studied before, and we're outside of any realm of evidence that medicine can point to?
Right. And what I'll be talking about today is that there's so little work relating ketogenic diet to so many factors that people assume have to do with heart disease as well as other diseases. I mean, we could talk about the microbiome. People are saying you've got to have fiber, you've got to have vegetables because these bacteria must feed on the fiber. Well, no one, as far as I know, has ever looked at ketogenic diet, the microbiome. So we don't know what really a healthy microbiome looks like in someone that's ketogenic. The same way with LDL. There's been insufficient work looking at LDL in people who are ketogenic. There's no work I know of looking at statin effects in people that actually go low carb. And my guess is who wants to fund that kind of study, right? Because the low carb will probably blow away statins as far as benefits. So the person that's going low carb, in a sense, and I say this, that you don't know what the outcome will be because there's never been a study on low carb or ketogenic diet and coronary outcome. Actually, sometimes people, some really atrocious work saying that low carb actually increases mortality. People die from low carb. Truly awful epidemiological work. But the answer is we don't know that ketogenic diet will reduce coronary events because no one's ever shown that.
Right.
It's reasonable to assume that because the biomarkers all move in the right direction, that you'll probably be protected from coronary events. And the LDL will turn out to be completely irrelevant.
So the argument, of course, saying the LDL still matters. Like, let me rephrase that. I guess there are two arguments. One is the one you just made. We don't know, and there's reason to believe it's going to be protective. The other is we don't know, so we really shouldn't treat this as a special circumstance until we do know, and we should lump it all together. And then if you go that route, and that's sort of the mainstream medical community would go that route, they really point to three versions of evidence to support that any elevated LDL is going to increase your risk. There's the Mendelian randomization, the genetic trials, which we sort of talked about with FH, but there's also the PCSK9 gain of function, so PCSK9 basically is involved in the degradation of the LDL receptors.
Right.
So if you have a higher functioning PCSK9, you're going to actually have more LDL receptors. You're going to clear the LDL faster. So there's a population that had a lower risk of cardiovascular disease with that gain of function, and thus the development of the PCSK9 inhibitor drugs. So just a study like that showing benefit from lower LDL with higher receptor action. I mean, is that enough to say, okay, there is more evidence there to say that a lower LDL is beneficial for some people, so therefore we should err on that side?
Yeah, the original PCSK9 work was based on people who had abnormal PCSK9, and so they had significantly higher LDL receptor density, therefore lower levels of LDL and somewhat lower levels of coronary events. But that was really related to a relatively small number of people, showing no overall mortality difference between those with the PCSK9 abnormalities and the controls. Now, the recent work, and again, the target is LDL because that's where all the money is.
Right.
The recent work has targeted the PCSK9 inhibiting drugs. The thing that's so important to realize is when someone takes this drug, what they're doing is increasing their LDL receptor density. Okay, which is abnormal. There are beautiful negative feedback systems to maintain LDL receptor just at the right level. This drug blocks the negative feedback, so you're increasing LDL receptors, meaning where's that LDL going to go? It's going to bind to these receptors and go into the cell. So the cell is going to become chock full of LDL that really shouldn't be there. The cardiologists love this because now the LDL is taken out of the blood. So you drop LDL levels by 70%. But that LDL doesn't disappear. That LDL is being crammed into liver cells. And ultimately, my prediction, they've only looked like 2 years now. And there's no real difference in cardiac events when you look at the PCSK9 trials. My prediction is you're going to see a really screwed up liver. You're going to see liver damage occurring in these cells that have too much cholesterol inside them. And so 5-10 years down the line, you're going to be looking at people that are going to be harmed by this drug.
Yeah, that's a great hypothesis. And we need longer term studies, obviously, because so far they've been 2 years. In defense of the PCSK9 inhibitors, they take the highest risk patients already on a statin.
Right.
They give them the PCSK9 inhibitors. They drop their LDL down further. 2 big studies. One showed about a 1% reduction in cardiovascular events with no mortality difference. One showed a 1.5% reduction with a small mortality benefit at 2 years. So the proponents say, look, if we had this effect at 2 years, think of the effect we're going to have at 10 years.
Of course.
And of course, your response is, what are the side effects and the risks going to be at 10 years? And we don't know the answer to that question.
We don't know that answer.
Yeah.
Right.
Yeah. All right, so there's the Mendelian studies, the genetic predispositions. Then there's the epidemiological studies, which we sort of touched on, but studies like Mr. Fit, like Framingham, which showed this association between total cholesterol and LDL and cardiovascular risk, although a small association, but an association. Now, what
Could
about age?
Could I interrupt you?
Yes.
I'm going to be talking about Mr. Fit today.
Yeah.
This is an amazing study because Mr. Fit showed a 400% increase in coronary mortality based on cholesterol levels, going from the lowest to highest. And it's actually right now at the University of Minnesota website, you can see Mr. Fit. And this is looking at about 400,000 men, middle-aged men, and they got their cholesterol levels and followed them for quite a few years, 7 years. The mortality rate from the lowest to the highest men was 1%. The actual mortality rate was 1%.
Yeah.
And they have distorted this to turn it into a 400% mortality rate. So you mentioned Mr. Fit. That was an abomination of science. Framingham, I think it's all very clear. When you look at unhealthy people, you look at LDL in an unhealthy environment, potentially it's either trying to save the unhealthy environment or it's a part of it. But again, it means the patient needs to sort of take his life into his own hands or her own hands. They need to take control of their environment. They're not going to find health in a pill, has been my point.
Yeah.
And so the person that has diabetes and is obese thinks that they're going to be protected by taking a statin. Well, the answer is still they're going to be very unhealthy.
Yeah, and that's one of the traps we fall into as a medical community, just trying to make things so simple on the patient, make it easy for them, but that easy doesn't always work.
Right, and so for the person that's going low carb, improving all the biomarkers, and yet they're still concerned about the LDL. So when we look, again, getting back to 4S, which I think is so incredibly important, the 4S trial, again, run by the drug companies. And so even though I'm skeptical, I'm looking at the data and going, wow, this is amazing.
Yeah.
The people that have the kind of biomarkers you see with someone on a low-carb diet showed no benefit whatsoever with statin treatment. That tells you a little something about what to predict when we have someone that is low-carb, and therefore they don't need the statin because there is no benefit.
Right, not proving that the low carb eliminates the benefit because that wasn't tested, but you can draw the hypothesis with that evidence.
And there's every reason to believe the adverse effects don't discriminate. There's no reason why there shouldn't be adverse effects in someone on low carb. And so adverse effects are simply the statin affects physiology. So potentially they're looking at the cognitive effects and the muscle damage and liver and kidney effects as well.
So what's interesting though there, when you specifically the cognitive effects and the risk of diabetes, I mean, that's what low carb is purported to be able to benefit. So I would like to think that that would be a safety mechanism to hopefully reduce those side effects. Again, no data behind it. But it certainly makes empiric sense. So if I have someone on a statin, I actually want them on a low-carb diet, one, for the metabolic benefits and to help with the LDL beyond what a statin could do, but also to help reduce potential side effects. Now, you've pointed out to me that there was a paper actually showing some beta cell dysfunction in the pancreas, so maybe low-carb isn't going to be enough to help reduce the risk of diabetes.
No,
What do you
not
think
at all.
there?
When you think cognitive effects, the brain makes its own cholesterol. and it needs the cholesterol to make new brain cells to make memories. Well, we published a paper showing that the statins that actually are lipophilic, which means they can get into the brain, are the ones associated with adverse cognitive effects. And so that statin is going in the brain independent of whatever that person's diet is. It's interfering with brain cholesterol synthesis, which is essential for making memories. And so, no, I don't think it has anything to do with the person's diet. This is now just simple physiology.
Right.
You interfere with cholesterol production in the brain, you're going to interfere with brain functioning.
Yeah. And the critics say it's difficult to measure that because if statins are being used in the elderly population, elderly people are going to get reduced memory function anyway. How do we quantify it without a trial? Same thing. But it comes down to, what are you most worried about? Are you more worried about developing Alzheimer's disease and cognitive decline, or a heart attack? And as we age, that may change. And age is a fascinating subject when it comes to cholesterol and LDL in general, because whether it's Framingham study, whether it's the Honolulu heart study, or there are a number of different studies, taking it together, it suggests there's, again, a bimodal response. Maybe in the 50s and younger, there's a tighter association between LDL and cardiovascular risk. But in the 70s and over, that association seems to flip. And you've been very big about pointing that out. So tell us about that difference.
So what I would still go with is risk factors. What you've got there are risk factors that kill people relatively young. Smokers and diabetes. These risk factors potentially interact with oxidized and small dense LDL at a younger age. You make it into your 70s and 80s, then basically you probably don't have those risk factors. You're much less likely to have the risk factors. And so you don't see obese people typically living into their 80s and 90s. And in fact, what you do find is the people with the highest LDL, and this is over 50 years of longitudinal studies, people with the highest LDL actually live longer than people with low LDL. So again, it's completely inconsistent with the idea that LDL causes harm on its own. And we published this paper in BMJ Open a few years ago. We reviewed every paper that had looked at mortality in relation to LDL levels. There wasn't a single paper that showed increased mortality in relation to the general population in older people that's over 60 with the highest LDL compared to lower LDL. So that's completely inconsistent with the hypothesis that LDL itself is causal to heart disease, because it's not killing older people who are at the highest risk of death from stroke and coronary heart disease.
Yeah, and the comeback there, as well as people get sicker, their LDL declines. So as they're on their deathbed, their LDL is going to lower.
That's the sort of the reverse causality argument, which really completely fails, because it's not looking 1 year after someone's had a blood test, which actually does happen. Someone dies, often you do find the year before death, especially if it's a cancer death, LDL levels do decline. But these are 10, 20, 30, even 40-year longitudinal studies. You got a blood sample from someone in their 50s or 60s, and then 20 years later, you look at who's died. And so you're looking years beyond. And these are people who have good health to begin with. And you eliminate any people that had died in the first couple of years. You're still looking 20 years later. Those who had the high LDL in their 50s and 60s are still living in the 80s and 90s.
So again, observational data doesn't prove that the high LDL is what is improving their health, but certainly flies in the face of high LDL is dangerous and going to kill you.
These are completely inconsistent with the idea that LDL is causal. I mean, it would be so simple if essentially, it relates to me also to the vegan versus the carnivore diet. Vegans love to say how bad red meat is for you. Well, if only the people with eating red meat would just die in their 40s of heart attack, it would be so simple.
Right.
Well, if the people who demonize LDL and they say, well, it causes heart disease and people die, well, if people with high LDL would just die, in their 30s and 40s, it would be so simple.
Right.
But they don't. The people with high LDL are living into their 80s and 90s and even 100. We're going to hear that today, that the people 100-year-old have the highest LDL of those measured. It just simply makes sense. It doesn't make sense to think of this as causing heart disease. There is an environment, a toxic environment. You will find LDL, especially in the younger people. The toxic environment has to do with smoking and high blood pressure. And so again, if we think about LDL coming to the rescue, now the reason why we want to think about LDL being beneficial is that people with FH have a lower rate of death. Again, got to emphasize, it's not statins. People in their 70s have a 40% reduced rate of death because they have a normal rate of death from coronary heart disease, but lower rate of death from non-coronary heart disease in their 70s. Less death from infectious disease, less death from cancer. this is the way to look at it, that if you make it to your 70s with high LDL, you've got a more protective immune system and no difference in cardiovascular death.
Yeah. It's interesting to see it, and certainly not talked about from that standpoint.
There's no money in talking about LDL as protective.
Right.
Right.
Right. And then there's a concern about time of exposure. That has something to do with it, whether you have LDL in your 40s or LDL in your 70s, that it's a different, a whole different environment, different time of exposure. But more than time of exposure is likely what else is going on from other risk factors in metabolic health.
The person that has FH and is in his 70s
they've
has
had
70
their whole
years
right.
of exposure. And so, again, they call that lifetime LDL burden.
Right.
And if you actually look at their work, the one you cited earlier, they're saying that FH untreated, you can expect people to be dying in their 30s and 40s. And again, that just simply doesn't happen.
Right, right. Where else to go? There's so much to talk about here, so much more. You have been criticized, and anytime anybody goes against the mainstream medicine, of course, they're going to be criticized. But one of the criticisms has been that you're cherry picking your studies and cherry picking the data. How do you respond to that?
Yeah, I think you're talking as a category. The people who criticize statins are called statin deniers.
Right.
Are cherry picking the data. And actually the criticism goes beyond that. They just simply say this is an internet cult. Steve Nissen says these people aren't real scientists. I have no bias whatsoever. And again, I'm just a scientist. My first priority was to improve my own health. I have no reason to be biased to pick the studies that would basically make a point for me if I want to be showing that LDL is not harmful. And I pick those studies, but ultimately I don't care about my own high LDL. I mean, it harms my own health. So I have no bias. I have no interest in this other than looking at good science. I want to look at all the science and come to valid conclusions as a scientist. Because I get no money from this, I have no pay, I have no funding for my interest in cardiovascular work. It's purely a personal venture for me. I don't want to be biased. I don't want to cherry pick the data. I'm looking at the entirety of the literature and I'm coming to conclusions.
Yeah. And so it leaves us as doctors and clinicians facing someone who's improved their health, improved their blood pressure, improved their metabolic parameters, but have a high LDL, being confused what to do. The average doctor out there who doesn't see this every day is going to have the knee-jerk reaction that this is dangerous. Some are saying you can ignore the LDL completely and don't worry about it, and some are saying we have to, really put it into context. But it's because of work like you, because of Zoe Hartcomb and Asima Holcher and Malcolm Kendrick, people who are willing to go against the juggernaut of the medical community and big pharma to say, wait, we need to look at this differently, that allows clinicians the ability to say, okay, wait, this is something different. There is something to this. So you've put yourself out there to really help move this forward. And you've gotten a lot of attacks for it. I mean, has your skin really thickened from this? And
I'm not sure what attacks you're talking about. I think in general the statin advocates have ignored to a great extent the people who have been critics. I know it came out, there was an article in the UK paper recently specifically criticizing Zoe Hartcomb, Malcolm Kendrick, Ufi Ravenscoff. They left me out, I guess, because I'm not a UK person. But that article was truly awful. Attacking them and saying, how wrong they are.
Yeah.
But really, I don't even think we're not coming out against pharma, speaking for them as well. There is no bias whatsoever. I am not looking to praise LDL. And I would grant that the small dense LDL, which is an abnormal LDL, may be contributing to the disease along with, it's almost like small dense LDL may very well be the gas on the fire, but it didn't make the fire. So I don't take it personally. I do recall that there was a cardiologist, actually at Duke University, who wrote an op-ed specifically about me, saying that I was causing harm to her patients, that people would die because I was explaining how statins have adverse effects and overall the adverse effects are greater than the benefits. To which I wrote a rebuttal to that cardiologist's reply. So yes, there was one example I can think of in which I personally have been attacked.
Yeah.
But then again, to me, it's all just science. It's not something I take personally.
I think that's a good perspective. It's all science. And actually, just to talk quickly about that article in the Daily Mail where they compared LDL deniers, cholesterol deniers,
Right.
to the anti-vaccine movement, which I
Right.
think is fascinating because they drew the comparison to the doctor who was falsifying data about the vaccines.
Right.
And I thought that was awful. I mean, that was
Yeah.
clearly overstepping the bounds because you're not falsifying any data.
Right.
You're helping us see data that already exists that other people did that's either being ignored or being promoted in a different way. You're just helping us re-see that data. There's no falsification there.
Well, there's a strategy in combat, which is to dehumanize your enemy.
Yeah.
So what people will do is say, well, they're not real scientists. So you can call them an internet cult. You can say that they're just like the vaccine people. And that way you, in a sense, you dehumanize them, you denigrate them, and therefore they'll have less credibility. And that's just wrong.
Right.
What we have to do is really talk about science, and I'm open to any aspect of the science. From the very beginning, I just wanted to learn how is it I can make myself healthier. And what I realized is I did ignore the LDL, and I ignore my LDL now, which is quite high. And what I really care about and what I know what matters is blood sugar, triglycerides. HDL is important, but it is the canary in the coal mine. You don't want to take a drug that'll raise your HDL.
Right.
HDL tells you about your lifestyle. Triglycerides tell you about your lifestyle and tell you you're consuming too many carbohydrates. LDL doesn't tell you much of anything.
Yeah. And I think that's a great point. A great way to sort of summarize this is, are we talking about causation, or are we talking about markers of our underlying health and our
Right.
underlying lifestyle? And that's what improves. I mean, so much of that improves with a low-carb lifestyle. Those
Right.
markers improve, which then should give us the evidence that improves our health down the road. And I hope we get that long-term evidence. In the absence of it, though, there's certainly plenty of reason to believe it's going to be so.
That's a great summary.
All right, very good. Well, thank you for joining me. I really appreciate it. And where can people hear more about you and more about your thoughts and your research?
Well, I don't sell books. I don't have a book. I don't have a blog. I don't have a website. This for me is still, it's personal. I have my day job in which I still do my neuroscience research. I will be, I actually don't have any talks planned in the future.
Okay.
For me, it's more important to be able to write medical publications. So I'm in the process of writing more papers to be published in medical journals. So I'm really approaching this as a scientist. I don't promote myself as anything. I'm not making any money from this. So I welcome the opportunity to talk with you. I thank you so much for inviting me. But frankly, I have nothing to share as far as promoting myself.
Well, that's a breath of fresh air. We don't hear that very often. Well, thank you for doing that. I appreciate it.
You're very welcome.